Welcome to the Functional Medicine Doc Talk podcast. I'm your host, Dr. Kurt Woeller, talking with experts in functional and integrative health and medicine, discussing critical information for improving your health and wellness to help you live a long, full life. Let's get to it. Hi, this is Dr. Kurt Woeller. In this episode, I have a conversation with Dr. Erica Peirson. Dr. Peirson is a naturopathic physician with 20 years of clinical experience and specialized training through the Medical Academy of Pediatric Special Needs. That's called MAPS. She is a fellow of MAPS. And her passion for pediatric care was sparked by the birth of her son and further shaped by nearly 14 years of work at Shriners Hospital for Children during her undergraduate and medical education. Dr. Peirson has dedicated her career to optimizing the health of children with neurodevelopmental and genetic conditions using a functional and biomedical approach. And she specifically brings this experience in helping children with Down syndrome. So this particular conversation is going to focus on the use of functional and integrative medicine and what's sometimes called the biomedical approach for children with Down syndrome. This episode of Functional Medicine Doc Talk is proudly sponsored by Mosaic Diagnostics, a global pioneer in specialty diagnostic testing, whose mission is focused on restoring health by addressing the root cause of complex chronic disease. Here is my interview with Dr. Peirson. Erica, welcome to the podcast.
Hi, thanks. Great to be here.
So before we get into the main topic here, give an overview of your education and training. And then I also want to know how you became interested in working with individuals with Down syndrome and other special needs, and that would include children with autism.
Yeah, so my background, it goes far back. I won't go all the way into my background, but I was raised with a cousin of mine who had special needs, and I was always kind of particularly interested in hanging out with her more than my other cousins. So I've always been drawn to children with special needs, you could say. And then many years later in my 20s, I started working at Shriners Hospital for Children in Portland, Oregon, and that kind of reinvigorated my interest in helping these children. And I worked there all through undergraduate schooling and my medical training at NUNM, National University of Naturopathic Medicine. And then, so I worked there for 14 years at Shriners Hospital, learned a great deal, of course, while I was receiving my naturopathic training. And right towards the end of that training, I think it was after I got my degree, my son was born. I think it was my first year of practice, and he happened to be born with a condition called mosaic Down syndrome. It's extremely rare. The extra chromosome is in a certain percent of his cells, not all of them. And that really sparked my interest, of course, in what's the biochemistry of this? How can I help him, right? How can we optimize this? And then I started to see that other children, with full Down syndrome, full trisomy 21 as we call it, needed help, right? Parents were online looking for answers, looking to give vitamins and looking to support their kids, and they needed some guidance. And so I started kind of opening up my practice to seeing them. So that was really the spark. And then it led to, of course, people reaching out with other genetic conditions. And then I saw the commonalities of what they experience with children with autism. So it's just grown. Yeah.
Being a naturopathic physician, going through your training at Shriners, were you able to implement naturopathic therapies there, whether it's nutrition or botanicals or homeopathics, these types of things?
No, when I was at Shriners Hospital, I was just, I wasn't practicing medicine. I was just, support staff. And so I was just there observing, but what I did learn was the labs that they were ordering and a lot of the conditions that they were treating. And so it gave me some background in just kind of that conventional aspect of medicine. Yeah.
For those listening to the podcast who are not familiar with Down syndrome.
Yeah. Mm-hmm.
Just briefly, what is Down syndrome and maybe the overall prevalence? Because then you mentioned also the mosaic forms. Maybe you can expand on that.
Yeah, really great. So there are different forms of Down syndrome. So specifically, it is an extra copy of chromosome 21 that in what we call full trisomy because there are 3 copies, trisomy 21. There's an extra copy in every cell of the body. There are other forms of Down syndrome called, one of them is translocation Down syndrome, where just a piece of the chromosome 21, there is a 3rd copy, but it's only a piece of it, and it's found attached to another chromosome, typically still within every cell of the body, but it's considered, sort of partial Down syndrome because you're only getting a piece of that extra chromosome that's attached. I think it's typically attached to chromosome 14, but I'm not totally sure that. And then, like my son has, is mosaic Down syndrome, and that varies widely because that can be in anywhere from 5% of the cells, 10%, 80% of cells at the time of testing. And then that can vary throughout life, of course. It's really, quite complex. So it's that extra chromosome that really plays the role and, changes the physiology a little bit. Yeah.
So unique medical challenges. So we know that a lot of genetic disorders have could be heart problems, it could be liver problems, digestive problems. Are there unique medical challenges to an individual with Downs?
Yeah, absolutely. There is a higher rate of heart defects born to children with Down syndrome, atrial septal defect, ventricular septal defect, PFOs, etc. They're usually corrected pretty early on, oftentimes with, very few complications, sometimes with significant complications. And as you mentioned, gastrointestinal issues are common. Autoimmunity is common in this they experience a lot of things. It's far-reaching implications for this extra chromosome. Celiac disease is common, hypothyroidism, sleep apnea, right? Those are some big ones, yeah.
I remember having a conversation with you a number of years back about thyroid problems.
Yeah.
In Down. Is it typically hypothyroidism, hyperthyroidism, a mixture of both? Because if it's an autoimmune condition, I guess it really could be both.
Totally. We have seen some children with hyperthyroidism with Graves' disease because they have an elevated TSI, thyroid stimulating immunoglobulin. It's more rare, It's more rare to have that. Typically what we see is hypothyroidism in this population of children. And the cause of that is complex. It doesn't always just involve, although the conventional model would do this, it doesn't always involve just give them thyroid hormone and check their numbers and move on. The cause of hypothyroidism in this population can be very complex, can be nutritionally based, can be metabolic, that drives the hypothyroidism. So yeah, it is very common in this population of children. So it's where I started my path of helping these children. I saw the prevalence of hypothyroidism and how, in my experience and training, it was kind of being mistreated or not treated correctly within the conventional model. So that's kind of where I started, was looking at their thyroid prevalence and treatment.
I want to talk to you about how conventional medicine approaches this syndrome, but what about the autoimmune? You mentioned autoimmune has a higher prevalence in this population. Any ideas why?
Yeah, so there are several studies that are looking at, certain interleukin levels, IL-6, TNF-alpha, that are elevated in this population of children. And of course, these research papers attribute all of that to the extra chromosome. And while there are some genes, I can't quote them just yet, right off the cuff, but that do play a role in these interleukins, we also know that these certain interleukins that contribute to autoimmunity can come from gastrointestinal issues, like in the typical population, right? Elevated levels of inflammation can contribute to autoimmunity. So it's not always just Down syndrome, they have autoimmunity, because not all of them have it, right? Not all of them have autoimmunity. So it can't be just the extra chromosome. One really interesting factor that I came across, a topic that I was fortunate enough to lecture on at MAPS, this topic called immunometabolism, where our metabolic rate, and this applies to all of us, but particularly to our children with Down syndrome, that our metabolic rate is a main driving factor in our immune system function, And when our metabolic rate is under functioning, we can have a higher risk of autoimmune conditions. So metabolism playing a big role is really immunometabolism. It's a fascinating area and papers to read. Yeah.
That is fascinating. I could take that part of this conversation.
It's really good.
Yeah. You mentioned about those cytokines, interleukin 6, tumor necrosis factor, I think you said. So it's interesting. Those tend to be often elevated in children with autism. And there's research that's been out there for years documenting this.
Yeah.
And there's more coming all the time. It crosses over into neuroinflammation, multiple triggers. So if you have a genetic tendency to those pro-inflammatory cytokines, then you can look back at things that might trigger it. And one of the things that's being discussed now in the autism population is because of these increased risk of pro-inflammatory cytokines and then environmental exposures that trigger it, autoimmune type of reactions. And now looking at moms who may be carrying some of those tendencies themselves, whether it's genetic or they've been exposed to something environmentally that's driving the inflammation or autoimmune tendencies, and then that crosses over into the child, that primes that child if they're then exposed to environmental things themselves, whatever, that can manifest as autism. Does this at all play a role, do you know, in Down syndrome?
Yeah, certainly. There are papers that look at the health of the mother of children with Down syndrome. Now, we know that mothers who are older, right, there's a higher risk of having a child with Down syndrome. And certainly as we get older, we just innately have more challenges with oxidative stress, metabolism, maybe even methylation, right, depending on our diet and genetics. So, yeah, definitely all these factors can play a role in our bodies, right, creating a child with Down syndrome. We can also look at grandmothers. That's the part that's, really interesting because as a female, right, all of our eggs that we will ever create in our lives are created when we ourselves are in our mother's tummies, right? When we are a fetus, right? I'm sure you're aware of this.
Very interesting.
So your listeners know that, when I was born, all my eggs that I would ever have were developed in my mom. And so her health is really important. So we look at grandmother health. This is a phenomenon that's well studied and kind of known within our field. So the health of those eggs is really important. But then, of course, after we're born, all of the other, as you mentioned, environmental factors are very important.
That has huge implications for so many things.
Absolutely. Yeah.
Down syndrome for sure, but other types of genetic disorders or neurodevelopmental problems. That's really, for sure.
Yeah.
How does conventional medicine approach an individual with the syndrome?
Yeah.
Typically?
So, there are standardized kind of guideline-based models that focus on screening and early intervention, management of these common comorbidities, but they're standardized, right? And their primary goal is to kind of monitor health risks, a little bit of what we've mentioned already, but really just providing supportive therapies and addressing complications as they arise. So it's a little bit different than my approach, but I think the key word there is that it's standardized, right? They're looking at all these children under the same lens, that because they have Down syndrome, they needed to be treated in this one specific way. And while those guidelines are helpful so that things don't get missed, there are still things that are getting missed. Yeah.
Do you see that as maybe being blinded or swayed a bit by the diagnosis? And so you just sort of stick to a standard protocol, and if anything falls outside of that, you either don't see it, don't recognize it because you're paying attention to this very limited list of issues?
You're right. Limited list of issues. Yeah, it's not individualized. And I think because these guidelines and things exist, doctors are in a sense trained to believe that children with Down syndrome aren't healthy or maybe can't be healthy. And so I take a different approach, right? So there are limitations to that kind of system. But look, doctors, they don't have a lot of time. So if we could just pause on that for a minute. That's in general, that's a big systemic wide problem we have with more than just our children with Down syndrome, is that we've got, 15-minute appointments, if you're lucky, to address a very complicated genetic health condition. And it's often not enough for these kids. Yeah.
One of the things we were discussing before was metabolic issues in Down syndrome. So why are individuals with Down syndrome at greater risk for things like nutritional deficiencies or metabolic imbalances? Is it because of the immune system, or what else is going on?
Well, I guess I could answer that question in twofold. If we look at the genetics of the extra chromosome, which, side note, is expressing differently in every child, right? But it's still there. That extra chromosome is still there. Some of the genes on that extra chromosome are placing an increasing demand on certain biochemical processes in the body, because you've got extra genes, extra enzymes that are coming from those genes. So two of the areas that we look at that this extra chromosome can impact in that extra demand process is methylation. Right. Some of your listeners might be familiar with less methylation. It may be more than we have time to explain fully here. But certain genes on the extra chromosome, particularly CBS, cystathionine beta synthase, is on the extra chromosome, and it sort of drains the methylation cycle. We call it the hole in the bucket. Right. Right. So that methylation cycle can be kind of drained in a sense. And so that it creates extra demand on these methyl groups and things like B12 and folate and B6 and riboflavin and all the other factors involved in methylation. Superoxide dismutase is SOD1, is also on the extra chromosome, and that's going to create an extra demand on glutathione, which is also kind of related to methylation, of course. So just the presence of these extra chromosomes can alter some biochemical processes, of course, but they can be actionable, right? We can get in there and try to optimize things as best as we can. But the other side of that coin of, why these extra possible deficiencies and metabolic imbalances occur is gut health. I mean, gut health, right? That's the foundation of so many conditions. And so because gastrointestinal issues are so common in these children, these gastrointestinal issues can lead to malabsorption of nutrients. And these children are, I was just putting some studies together for my presentation at MAPS in September, that they receive twice as many antibiotics as the typical population.
That's interesting.
So, which the typical population of kids already receive quite a few these days. And so because they receive more antibiotics, and my gosh, right, I've seen some 3-year-olds who've been on 12, 15 in their life, right? It's just antibiotic after antibiotic. And that's going to take a huge toll on their gut health. And then things can just spiral downward from there. Yeah.
So I have some questions I want to ask you. And you touched on part of it, this opening discussion about chronic infections, antibiotics. I want to come back to the methylation discussion. We don't have to get into all the chemistry of it, but when you talked about CBS problems, right, that downstream of transsulfuration. So you've got homocysteine, comes down through the transsulfuration pathway, supports detox, could be taurine, could be cysteine, and then glutathione. Is within the conventional medical world, have they looked at, do individuals with Down syndrome typically run low on glutathione?
Absolutely. Yeah, the research is there for sure. I don't always supplement it. I run tests to see, right, if they need it and what's going on, or I do often supplement it, but not always. We certainly use it when there's an extra need for immune system support. But yeah, they can struggle with glutathione levels. I make sure the building blocks of glutathione are there. Right. Glycine, cysteine, right? And then taurine, we will sometimes supplement as well. But yeah, I think that was your full question.
So if there's a tendency towards a glutathione deficiency, you also mentioned a superoxide dismutase problem.
Right.
Right. So that leads me to think then that there's going to be intrinsic cellular stress, oxidative stress. Mm-hmm. What about the role of mitochondrial dysfunction in Down syndrome? We know it's a big problem in autism and other types of genetic disorders. But if you've got glutathione problem, you've got SOD problems, you're going to typically have a mitochondrial problem or problems.
Yeah, so much I could say here, right? So just to pause on that SOD where you started, SOD is controlled. Our genes are controlled by the environment. So that gene in particular, all of them, they don't just sit there and spew out these extra enzymes like a ticker tape machine, right? Just kind of uncontrolled. It's just coming out. They're controlled by the environment, which is why I think I don't always see a need for glutathione supplementation, because that SOD gene not only varies because of SNPs and things, but it can vary because it's controlled by the environment. It's kind of upregulated as needed, right, if there's oxidative stress. So one of our other sources of oxidative stress is mitochondrial dysfunction, right? Especially the electron transport chain where oxygen molecules can escape and create reactive oxygen species. But mitochondrial dysfunction, I don't always see it in these kids, right? You chose a great word, tendencies. Right? So this is a term I use a lot. There are tendencies. I look for these tendencies, but not all of them have it. I just had an appointment with a kiddo today. It's the cleanest gut test I've ever seen was today on a kiddo with Down syndrome. And not coincidentally, she had a couple of things on her organic acid test, but mitochondrial function was spot on, right? It's rare. I don't always see it. But she had the extra chromosome like every other kiddo, and I think it correlated directly with her gut health, her nutrient absorption. And so yes, we do see mitochondrial dysfunction in these children often. It is related to some factors on the extra chromosome, but in my experience, it's related to their gut health, their malabsorption of particularly B vitamins, carnitine, CoQ10. I really see that much more strongly of a correlation than, the extra chromosome plays a role. But in my experience, it's not as strong as their gut health. Yeah.
Now, are some of the heart defects, are those more just anatomical from an embryological development standpoint, or have they linked any of those things to, let's say, a mitochondrial problem? Because you think about mitochondria, they're highly prevalent in highly metabolic organ systems.
Interesting.
Cardiovascular system, musculoskeletal system.
Sure. The congenital heart defects that we see are midline defects. So I see that more related to methylation in the mother.
Got it.
Right? Just like cleft lip and palate, right? Stork bites, whatever. Those midline defects, spina bifida, right? That's methylation. So the heart just not closing completely. So yeah. But might be a mitochondria. I know I haven't looked into that. Yeah.
The gut issues, you mentioned these kids are on a lot of antibiotics, which to me then it leads back to, as a child, usually ear infections tend to be problematic, and then things that can cause ear infections. I've seen it, for years. The consumption of milk and dairy allergy leads to ear infections and then secondary antibiotics. However, in Down syndrome, do these kids tend to have any type of abnormal orientation of the ear canal that maybe sets them up and be more prevalent to an ear infection, for example, that would then cross over to, hey, you need antibiotics because your ears are getting infected just because of an anatomical problem?
Absolutely right. This is a very challenging area for many of my patients. Anatomically, we see hypoplasia, slower growth of the mid-third of the face in children with Down syndrome. Partly related to, we believe, one of the genes on the extra chromosome is called DRCA1A. It's a dual specificity phosphorylation kinase enzyme, I believe, and so involved in this development. And so because they're smaller here, eustachian tubes are smaller, maybe they're flatter for a longer period of time. And then they just can't drain through their nasal passages and their sinus passages like we normally would, to the back of our throat. So it's very challenging. There are anatomical challenges. But then if you add on top of that a child who has reflux,
Oh,
It's like they're coming at it from both angles. It's a really recipe for a lot of problems because that reflux, of course, will cause extra mucus in the nasal passages. Because as you know, right, when a child has reflux or even silent reflux, there's nothing stopping that acid. Once it passes the lower esophageal sphincter, it's open pathway up to the sinuses even. There have been some studies in children, real quick, who, not with Down syndrome, where they tested the fluid in their ears and they found pepsin and they found bile in the fluid in their ears, knowing that it was stomach contents that were coming up. And so the body will create mucus in order to protect it from that acid. And that's just, so we work on gut health when there's lots of mucus there.
Now, are there anatomical issues? A short esophagus, a problem with the cardiac valve? Are they just anatomically more prone to reflux problems?
Well, there are some anatomical issues that can happen. There's a duodenal web that can sometimes happen. I think it's more prevalent in our kids, which is just that. It's like a spider web of tissue that some food can pass through, but large particles can't, like a little net that sits there. There's duodenal atresia, which is really serious. That's caught pretty early. That's where it's completely blocked. But in terms of the most common causes of reflux in our children are due to low muscle tone. Because the gut, the whole system, tongue to anus, right, is very muscular, right? The stomach has 3 layers of muscles. The whole intestinal tract has 3 layers of muscles that are working strongly and churning to move the bolus of food through. And when we have low muscle tone, the gut is going to move more slowly. It's really that simple. The same mechanism that's contributing to low muscle tone, whether it's hypothyroidism, mitochondrial dysfunction, certain nutritional deficiencies, will translate to slower gut motility, and that will cause reflux, as well as other issues kind of lower down. Yeah.
So one of the other things it can lead to is the overgrowth of bacteria, fungus, small intestinal bacterial overgrowth scenarios in the large intestine because of peristaltic activity. So you're seeing those same types of things in these kids that we see in other special needs children.
Yeah.
So what laboratory test and assessment do you often find most helpful beyond, let's say, just standard screenings?
Yeah, so standard screening for our kids would involve like a TSH and a T4 and maybe a CBC, right? I go much further with that. Just from a lab perspective, I like to look at more nutritional levels. I definitely want to see an iron level. Iron deficiency is very prevalent in this population of children due to malabsorption. And that has long-term implications on IQ. We know that from, many studies of iron in general. So looking at iron, B12, zinc, and copper. I look at histamine levels in the blood. I look at a lot in the blood. That goes a little bit deeper than a conventional practitioner might. I call that kind of low-hanging fruit, right? Let's just make sure there's no just basic deficiencies, just iron, those kind of things. And then functionally, like yourself, I've done, thousands of organic acid tests on these kids. And that's where I started to see the pattern over and over again. Not only one, that they're all different, but 2, that when the gut issues are there, the nutritional deficiencies are going to be there. So lots of organic acid testing, and then the comprehensive stool analysis. That's my basic. I want to see that. I wish I could see that on just about every kid. And then we do other things as warranted, mold testing, heavy metals, etc. Yeah.
Well, and through your naturopathic training, you're going to put a naturopathic physician's lens on a blood chemistry. So
exactly right.
Yeah. So you've got a different way or more in-depth way of looking at a blood chemistry beyond just a pure deficiency that's obvious on the test, but looking at things from a nutritional standpoint. And that's super important.
Yes, thank you. That's one thing I'm really passionate about are those reference ranges within labs. Oh my God, right? They're often like horrible.
Yeah.
These reference ranges, right? We've got to have our optimal reference ranges that we get from reading, research, colleagues, conferences, whatever. So those reference ranges in labs from, anything from an MCV to a potassium level. I just did a blog post on potassium. can be way off and really kind of, in a sense, causing harm when those reference ranges are not detecting a deficiency, because those reference ranges are capturing some undiagnosed pathology in the typical population. We're going to get, low levels in those reference ranges. So, so I'm looking at things with a fine-tooth comb. And then when I do find a deficiency, I don't just say, oh, you need this. We ask why. What does it mean? Right? We go, much deeper.
Yeah, the asking the whys. Well, the big one, Erica, is the too broad of a reference range for TSH. So the thyroid stimulating hormone, that's always, but that's been a well-known issue that within the functional integrated medicine world has recognized. And then oftentimes with a standard blood test, the TSH is the only thing that's done. And so you don't get an assessment of the free T3 or the free T4 or these other thyroid markers, which are important. So, I mean, that, and then just adding this to the conversation of Down syndrome, one of the things you mentioned is hypothyroidism is a huge problem. So I know you know this, obviously you're looking at this.
Yeah.
You've got to see, a lot more thyroid problems on these blood tests with these kids than would be picked up by conventional practitioners.
Yeah, absolutely. We do often see low T3 levels, right? Because the conversion of T4 to T3 is dependent on those deiodinase enzymes, which are dependent on things like zinc and selenium, which are often low in these kids. So we'll see high reverse T3 in these kids because of malabsorption and just general kind of low calorie intake from that malabsorption will cause a high reverse T3. And if you check those things, you're not going to detect it, right? Not going to pick it up.
One of the things that you mentioned prior to this recording in some of the questions we're going over was diagnostic overshadowing. What is that, and how does that impact those with Down syndrome?
So diagnostic overshadowing is a cognitive bias that a lot of healthcare practitioners carry. They don't know they're doing it. So healthcare practitioners and doctors, where they're assuming that all of the patient's symptoms, ailments, illnesses are attributed simply to the fact that the child has Down syndrome and no further investigations are done. And, talk about harm. I mean, this leads to delayed diagnosis. If the diagnosis is ever made of something else that's contributing to a condition, delayed treatment, and in many cases, poorer health and even neurodevelopmental outcomes, right? So it's a really harmful phenomenon that happens not only in our community in Down syndrome, but autism and other similar conditions that they just say, oh, this is normal for right. Constipation, bloating, not growing. That happens,
I have seen that for years. In fact, I remember giving a lecture on that where I gave an example. You take a 5-year-old child who has chronic allergies, failure to thrive, chronic digestive problems, anxiety, sleep issues, etc., but they do not have a diagnosis of autism. Typically, the medical community would say, we need to do some testing. Do a stool test, maybe there's an infection, do some blood test, whatever. Take that same child, put a label of autism on them, and everything then is labeled to their autism. And if you actually look at the diagnostic criteria for autism, nowhere on there is chronic diarrhea, chronic allergies. Right? These are medical issues. So it's interesting, but also, I guess, disheartening to think that this type of thing is happening in other special needs communities, but it's not surprising to me.
No. And I think the most we can do is raise awareness through these kinds of conversations, and so that parents know when and how to advocate when they're in the doctor's office, to say, no, I want more done. I want, let's look at other causes for this. So it unfortunately puts a lot on the shoulders of the parent to then advocate more when we're looking for the doctor for help. But yeah, I think raising awareness is really important.
Let's talk about genetics for a few minutes here. So you mentioned went through trisomy, issues, but is there any other emerging information that you're coming across that the research tells us, the genes that are affecting chromosome 21 and how they can impact some of these kids, or maybe the other neurodevelopmental problems as well in this population?
Yeah. The genes that are on chromosome 21 have been known for a while when they decoded the genome in the early 2000s. And it was very early on that they used that information to then say, well, how does this apply to our individuals with Down syndrome? And so they're looking at isolating specific genes like CBS, SOD, DRCA1A, in mice, in the mouse model. They're able to genetically manipulate them and then see what kind of agents can help with cognitive function, within this mouse model of Down syndrome. One thing that I think is not necessarily a new gene, but an agent that impacts these genes, particularly DRCA1A. I keep mentioning this one because it is one of the ones that is believed to play the biggest role in cognitive development, neurodevelopment in these children. And we know that EGCG, green tea extract, that one I cannot say what it is that EGCG stands for, but we know that EGCG inhibits this enzyme. So very early on, I don't know what the year of the study was done. I should have looked that up. I've been referring to this study. We've been for at least 10 years that they studied EGCG in the mouse model of Down syndrome, the mouse model, little mice with Down syndrome. And what they showed was that they were able to increase their memory of these mice. They use a water maze where these poor little mice have to swim through a maze of water, and it increased their memory within those maze models. So then they took the EGCG and they applied it to children with Down syndrome, gave them green tea extract at 9 milligrams on average, 9 milligrams per kilogram per day. I believe the children's ages were somewhere about 6 to 13. And it improved their cognition and memory. So a lot of my families are seeking guidance from me for dosing and sources for this EGCG, but also very careful monitoring. The researchers will always say, there's not enough research. Well, parents aren't looking to wait for more research. Right. So I think that's why they need a guide. Instead of just saying, don't do it, they're going to do it. Yeah. So we want to do it. We want to do it, really be really smart and safe about it, because these doses of EGCG at 9 milligrams per kilogram per day are quite high. I consider them pharmaceutical doses of EGCG. They can chelate iron, for one thing. So we've seen that in some kids who parents are using it and they're not monitoring their ferritin levels.
That's important.
I won't start EGCG until I see a ferritin at least 40. It's not 50, and I'm dealing with a lot of kids, low iron to begin with. I usually don't use it until they're at least 2 or 3, eating food, and we can, get it in, because it tastes terrible. So really hard to get it in. And then, monitoring. It can also inhibit the COMT gene, COMT enzyme. So I haven't seen that affect catecholamines too much in kids, but so that's been an interesting bit of research.
So inhibiting the COMT, that's going to affect things like dopamine, for example. Yeah, exactly. Which would be problematic if it's too high. So right. The ECGC, which we can get from green tea, which I get about 2 to 3 cups of green tea a day. I'm sure it's not to the level like this. But do they have an idea as to, is it influencing oxidative stress? Is it influencing synaptic connection? Is it influencing receptor binding?
That's a really good question. The only way I know how to answer that is DRCA1A is involved in regulating how brain cells grow and divide. So if we inhibit it, it will support brain cell growth. But the specific details, I don't have the answer to that. Yeah, unfortunately.
Here's one for you to look up. So there is actually a supplement that contains a certain version of ECGC that supports mitochondrial function at the electron transport chain.
Oh, interesting. What do you know the form of it is? Because I learned about one called methyl EGCG in a type of green tea called Benefuki. Benefuki green tea has a methyl EGCG in it, which is interesting. But you know of another form. Yeah.
I'm blanking on that. The supplement might be called Mitocatalyst.
Sure. Interesting.
I'm not remembering right now, but so you think about the ability of cells to, regulate themselves, divide, apoptosis, much of that's controlled or at least driven by ATP production, which comes from mitochondria. Sure. So a lot of connections here.
Yeah. Yeah.
Real quickly, genomic testing. So there's the genetic testing, right, that they look at from a disease standpoint and chromosomal standpoint. But genomic testing, looking at methylation and some of these other factors, how do you incorporate that into your practice?
Yeah, I do. I do incorporate it. I save genomic testing, like, looking at SNPs and things, for the end. There is no end, but I save it kind of last, right? I want to look at how the body's functioning first, right? I mean, I've been dealing with genetic conditions and this extra chromosome for a really long time. And I've learned that I want to see how the body's functioning. I want to look at the emissions test, as I see it, the organic acid test, and how it's functioning. And then when I get stuck, I'll want to look a little bit. I'll want to look further. Be like, there's some, and then I'll ask the parents, well, tell me about, what about your prevalence? And do you have this in your family? And do you get numbness and tingling? Do you get, so I'll start to look at family stuff to help explain. And then, these genomic tests are really helpful, right? When we do them, I don't do them first, though. Personally, that's how I practice. Other practitioners do them pretty early, but I save it for last when I can't get stuff done, because with the organic acid testing, stool testing, et cetera, because we can get really far with a kid with just those tests alone. Yeah.
Right. Just some of the basic fundamental things of natural medicine, naturopathic medicine, functional medicine, whatever word you want to put on it, those fundamentals are still very true. Yeah. And so what is your experience with children with other types of genetic disorders? You mentioned that you're getting parents that are reaching out to you. They may not have a child with Down syndrome, but they have some other type of genetic problem and just are seeking your assistance. Yeah,
totally. So we have seen children with many other conditions, some very rare. I've seen children. I saw a kiddo with Cornelia de Lange syndrome. He was very physically limited. I think he was about 4 or 5 years old, not feeding himself, not walking. And of course, all the doctors said he would ever do it. He would never be able to feed himself or walk. Well, of course, right? We do our work. We get in there, and of all things, he was thiamine deficient, right? And so, they were able to do an organic acid test, and he did beautifully, right? Got walking, was able to feed himself. Look, I'm not promising miracles for these children, right? We're not curing their genetic condition. We're optimizing. Right. Other conditions I've seen, Dup15q syndrome, Smith-Magenis syndrome, which affects melatonin levels.
Yeah, so I've seen a few kids with that too.
Interesting, yeah. And the research is very clearly there that they have lower melatonin levels. So mom ran a saliva test, $45-$60 or something, showed that he had low melatonin levels. And so we, among others, many other things we did. But yeah, absolutely, we can help these kids. Because if I just one more second on that, what if what a child is experiencing neurodevelopmentally, globally, whatever condition or aspect of their health and development we're looking to improve, what if 60% of that was due to genetics and 40% was actionable? I'd want 40% improvement. What if it was just 20%? Yeah, I'd go for that, right? I would do that thing, that organic acid test, that B12 supplement. If we could get them just that much closer to optimal neurodevelopment, of course, a parent's going to want to do that, even if whatever percent that is, because I know that in these children, it's not 100% their genetic condition. There's always a little bit more that's actionable, and that's another key word I use is actionable, right?
So the actionable concept is really important, as well as optimizing potential. I've talked about that for years. And my feeling is with everybody is there's hope and help for everybody. The whole point here is not to recover or cure. That's not going to be possible in all circumstances, particularly with these genetic disorders. But if you can help an individual with a genetic problem be more functional, be healthier, happier, then, I mean, that is a success. I just think, Erica, from the standpoint, you think about the chronic ear infections.
Yeah.
I remember as a kid, I had chronic ear infections. I had ear infections all the time. They were terrible.
Yeah.
And, if you're a child or you're a teenager that's dealing with chronic nasal congestion, or you've got, asthma or some kind of chronic problem, it's not all attributed to their genetic disorder. It's like work on their underlying health. You're still going to have an individual with Down syndrome, but they no longer have respiratory problems, or they have ear problems, or they have congestion problems. They're just happier. They're healthier. So
right. Exactly right. Yeah. Yeah.
You also do a lot of work with PANS and PANDAS in your practice. So first, describe what is PANS and PANDAS for people who maybe listen to this aren't familiar with that. And then I also want to ask you a follow-up. Is this scenario or situation prevalent in Down syndrome?
Yeah, sure. So PANS PANDAS is a condition where a child will typically suddenly, but if it's not caught when it suddenly happens, it can still be there, but typically it's suddenly, the child will suddenly develop severe changes in their behavior, their emotion. They might develop anxiety, OCD tendencies, food aversions. I mean, parents just say their child changed overnight. And typically it's triggered by some kind of infection. Our first experience, not mine, but the studies show that strep was a very common source of that infection, but we know that other infections can cause it. I've seen COVID cause it, mycoplasma, of course, the flu. And so these changes are caused by an immune reaction and inflammation within the body that changes brain chemistry. And so tell me if you've certainly, your audience probably knows a fair amount as well. I could speak more about it. There's an autoimmune component to it, of course. And a lot of children with Down syndrome do experience PANS and PANDAS. And certainly it gets missed in the typical population, and these kids just get medicated or whatever. But I would say it likely gets missed even more in the Down syndrome population because of diagnostic overshadowing. When there's changes in behavior, emotion, mood, kids with Down syndrome, this happens. Or the child is nonverbal and they can't tell when they have a headache or when their throat is sore or when they're unwell. So it's very challenging to detect PANS and PANDAS in these children. But with the right labs and tools and questions and things, we can, get in there and do it.
So pediatric autoimmune neuropsychiatric disorder after strep would be PANDAS.
Right. Yes.
And then PANS is pediatric autoimmune neuropsychiatric syndrome, I believe.
Yeah.
So the way I always describe those is PANDAS is triggered by beta hemolytic strep.
Strep, yeah.
PANS could be triggered by a bunch of other stuff.
Viruses,
Right. And you mentioned that there is a higher prevalence in Down syndrome with autoimmunity, which would bring us back to the fact that you've got autoimmune reactions that could be triggered, whether it's PANS or PANDAS, to the brain and creating instability in a brain standpoint. And then also, you mentioned early in the interview that there is a higher propensity to certain pro-inflammatory cytokines, right? So interleukin-6 or tumor necrosis factor, whatever.
Yeah.
So all of this takes us back, I feel, Erica, to this discussion of, yes, you have certain unique genetic characteristics in Down syndrome. Yeah, you have certain genetic characteristics in Smith-Magenis syndrome or these other types of genetic disorders. But when you break it down to the underlying biochemistry, the physiological relationships, what's happening at the cellular level, what's happening in the gut, what's happening in the immune system, what's happening in the brain. As a naturopathic physician, I mean, you were trained, right? I don't know if it's from day one, but I know earlier on in your training about the importance of nutrition on health, on gut on health. And if we think about all of these things, we can see how a child with Downs would be more prone to autoimmune problems, and look at the mechanisms as you start to unwind this process. And the same thing with autistic kids, and same thing in many of the other genetic type of disorders. Has it been your experience then that the Down syndrome kids are just as prevalent to have a PANS-PANDA situation as opposed to maybe an autistic child or somebody else?
Yeah, it's hard for me to answer, right? I'm in a bubble, right? I've got all my, I would say it probably is, probably more prevalent. I know that the rate of autism in our kids with Down syndrome is higher than the typical population, kids who have dual diagnosis. There are no studies out there to look at the rate of PANS and PANDAS because it's, well, one, we have to have more recognition in general, but given those mechanisms that you mentioned, I know PANS PANDAS is likely much higher in the Down syndrome population because of all those contributing factors. Yeah.
So the one thing I really want to stress to the audience, and whether this is a parent listening to this podcast or a grandparent or a practitioner, is regardless of somebody's diagnosis, their genetic condition, whatever. Look at what's happening to underlying issues of gut, nutritional imbalances, food sensitivities. There's so much that can be done to help these individuals improve their overall health and really just improve their overall condition. As you mentioned, Erica, you're not going to cure Down syndrome. They're going to always have unique characteristics and many of the other conditions, but they still can be helped. And that's, exactly what you've dedicated your entire life to and practice to. And it's wonderful.
Exactly. Yeah.
What are some key things you want a parent with a Down syndrome child to know with regards to functional integrative medicine? We sometimes call that biomedical intervention, but what are some key things out there that you want these parents to know?
Yeah, I think the tools that functional and integrative medicine and naturopathic medicine provide, they go much deeper than the conventional model. And while it may not be right for every parent, some parents do see that what I do is controversial, right? Believe it or not, they think that I'm trying to change these children or change the fact that they have Down syndrome. And I hope I've conveyed that that's not the case at all, right? My personal feeling is that there's nothing wrong with Down syndrome, to be honest, right? That they're just a normal part of humanity, and as they have been for, centuries, that it's not the Down syndrome I'm trying to fix, cure, or change, but through functional medicine, we can see how their body is functioning and make sure that we're optimizing. So to look in your area to see if there are functional medical MAPS physicians, someone who is willing to apply these principles, which is challenging if they don't have kind of my insight, I guess, to their child with Down syndrome. But yeah, there's just a lot of tools within functional medicine to help their kids. A lot, right? Yeah.
Not only being a practitioner, but a parent. You're going to have individuals out there, maybe some action steps that families can take to say, yeah, I want to do some things. Yes, I want to try and find a practitioner such as yourself, but I want to get started on some things. What are some common things that you've seen in kids with Down syndrome that a family could do that could just start to improve their child's health?
Diet, far and above, right? Anything else is diet. You can't out supplement a bad diet. And so if you have a child who won't eat their vegetables, won't eat meat, won't eat whatever, won't eat a broad range of foods, find out why, right? Could be a zinc deficiency, could be gut issues, right? Work on it slowly. But then also look at your family dynamics. Make sure nothing there is playing a role, right? Are you eating your vegetables? Is your child seeing you eat your vegetables? There are studies to show that if children see adults enjoying and smiling and carrying on about how good their vegetables are, they're more likely to eat it. There's a great website and YouTube channel called Copy-Kids, where there's just cute videos of kids eating vegetables. And then your kid could watch that if you're open to a little bit of screen time. But diet first and foremost is the number one. I see it over and over and over again, hundreds and thousands in my patients. And in my own experience with my son, the number one thing that helped him was that he was fed a good diet and that he was willing and able to eat a good diet, which told me that his gut health, zinc levels, et cetera, were healthy. And that is what set him on, such a thriving trajectory. So look at what's in your pantry. Look at what's in your refrigerator. Take gluten and dairy out if you can, right? For sure. That's definitely a first step. Those are the easiest kids and families that I work with if they've already done that step, right? They're already kind of many steps into the process of starting a healthy diet. So yeah, I just can't carry on enough about diet.
Well, typically too, if you have kids that have dietary deficiencies, they're going to be deficient in certain nutrients. If you got gut problems, they're not going to be absorbing things very effectively. You mentioned iron is often deficient in Down syndrome. Are there other vitamins that have been documented? I mean, vitamin D or some other things that tend to come up commonly? Yeah,
all of them, really. But yeah, vitamin D, common to be low. There's research supporting vitamin A is commonly low, but we test, we don't guess, right? Zinc is often low, but I've seen low copper, which is almost more detrimental, right? That causes significant neurological issues. B12 is often low, and then thiamine, right? We could do. You've done a great presentation at Mosaic Diagnostics on thiamine. So that is one of the most tragic, common deficiencies I see in my kiddos with Down syndrome is thiamine.
And I interviewed Chandler Mars. In the first season of this podcast, and on her work on thiamine. It's a really important nutrient. Is general supplementation, I want people to work with a professional such as yourself or their pediatrician. They can ask these questions. But in general, if we've got nutritional problems, is general supplementation something that's advocated for many of the Down syndrome kids that people can look at? Or is it best to really start with testing to know exactly what you're deficient in?
I like starting with testing so that I find where the most significant deficiencies are. We address those, bring a kiddo up to kind of baseline, and then I add in a multivitamin, the basics, right? Because if I've got a kiddo, here's another important concept. If I have a kiddo with gastrointestinal issues, SIBO, right? We have to keep in mind that every supplement and food and thing that we put into our child's mouth or that we eat, it hits our microbiome first. So I want to know what's going inside their gut before I load them up with a bunch of trials of supplements or even a multivitamin, because you could aggravate that and make that worse. And I've seen that. There are some kids who are using some protocols out there that are designed for every child with Down syndrome, and they'll give it very early to their child, and their reflux gets worse, their gut gets worse, and they're kind of miserable while they're on it. And they do better off of it. So I don't want to mess around too much if I've got a kiddo with gut issues, which many of my kids do. So I wait.
In autism, the gluten and the casein not only can trigger a food sensitivity and IgG reaction, which can drive inflammation, but you also have the peptides, these small, strings of amino acids, parts of proteins that have an opiate-like effect. So they interact with opiate receptors in the brain and nervous system, can affect behavior, can affect language, can affect eye contact. Is that same mechanism at play
100%.
in Down syndrome?
Yeah, 100%. Exactly right. Not only the peptides and the opioid effect, but of course gluten and molecular mimicry with its increased Hashimoto's, the dairy contributing to, as we believe now from research, the folate receptor antibodies, right? Really important to pull those. And there's actually a paper looking at what they called it, a dairy, we'll call it a dairy sensitivity in children with Down syndrome. And by pulling dairy, they had improved gastrointestinal and upper respiratory symptoms, right? Which we know clinically, but it's nice to see there's a research out there that shows that. Yeah.
I was going to ask you about the cerebral folate deficiency and the folate receptor autoantibody reactions.
Good. Yeah.
I don't know what the percentage of autism is in the Down syndrome population. So we know that a lot of the kids with autism are showing up either positive on the folate receptor antibody test, or they maybe have some genetic SNPs that affect the function of that folate receptor, and then they get clinical improvement when they're put on folinic acid. Is that the link, or is there something, I don't even know if we can sort of pull these apart, Erica, but is there something within the core aspect of Down syndrome that these kids have a folate problem? Is that something that's been looked at?
Yeah, absolutely. The methylation cycle being impacted, that CBS gene pulling from the depleting the methylation cycle creates a folate trap, right? Methylfolate will just be trapped within the folate cycle, and it can't move over into the methylation cycle, which is why we look at methyl B12 to do that. So folate has been looked at, of course, in Down syndrome as it relates to methylation. But if I could speak about those antibodies in my population of kids, I've done the FRAT test on about 26 to 28 kids, and I'm getting a rate that's similar to, it's only 25 to 28 kids. I'm getting a rate that's similar to the 70% that the Quadro studies show us, and the 63% that Dr. Wells and Dr. O'Hara got in their PANS-PANDA study. I'm seeing about a 60% rate in these kids of folate receptor antibodies.
Wow.
Now, my data might be a little bit skewed because these are parents who are choosing the test because their children are struggling a bit more. I'm not testing it in all kids with, the typical kids with Down syndrome. We're testing it in the kids who have a duodiagnosis. I'm particularly seeing it high in kids, parents who are listening might find this interesting, who have a condition called Down syndrome disintegrative disorder or Down syndrome regression disorder, where they have a significant regression. Some get even catatonic, and they lose significant speech. Maybe they'll start whispering. They lose, significant skills, ADLs, etc. And I'm finding a high rate of folate receptor antibodies in those kids. And when we provide them with leucovorin, a handful of these kids, we've gotten them back to baseline, like reversed that, right? Which we know the mechanism, right? And we see the efficacy of this leucovorin in many of our children with autism, not all of them, but I'm seeing it being really helpful for a lot of my patients with Down syndrome as well.
And what are you seeing it benefit? Because in the autism world, it's often linked to an improvement in language capacity. Same thing happening in Down?
Yeah, exactly. Yeah, we see improvements in speech. We improve improvements in sleep, which translates to everything, right? We see improvements in just their engagement, their cognition, just, their world gets bigger, right? They're just more aware. But definitely speech. Yeah, I have one case I'm hoping to publish of little boy who was 6 years old with Down syndrome, not walking, not talking, right? And his team said, well, this is Down syndrome. I was like, that's not Down syndrome. He's 6 years old. Right. A lot of kids with Down syndrome are walking by 2 and 3 years old. And so we worked with him for a couple years, and finally I was, the FRAT testing came on my radar, and he has very high both binding and blocking antibodies. And so by 10 years old, we started him on leucovorin, but thiamine got him walking. And then started on leucovorin. Now he's got some words, and he's much more engaged, and sleep. Mom says his sleep is the best on the leucovorin. So it's been remarkable for some kids. Yeah, really life-changing.
Most of the information, at least the early information on the autoantibodies against the folate receptor were linked to dairy, particularly cow dairy.
Exactly.
And that's sort of expanded now into other animal dairy. Mm-hmm. Could be camel milk, it could be goat milk.
Yeah.
Are you seeing that as a strong link in your practice as well? I mean, we think about just removing dairy from a lot of these kids, and sometimes you see great improvement, but we don't necessarily always understand what the mechanisms are.
Yeah, I've seen, I have a couple of kids who have the positive antibodies, and I have an Excel spreadsheet where I'm keeping track and whether they've ever had dairy in their life, which is rare for a child not to ever have it. But I have a couple kids who parents knew from the get-go not to give their child dairy, and they still got these antibodies. So, but one of the moms, she tested herself and she was positive. So there's something familial being passed on also, potentially, I think, which Quadros' papers refer to. But in most of them, there's dairy in their history, so it's hard to tell, what the trigger was. Yeah.
I'm suspicious there's other things causing that cross.
Exactly. Yeah.
Antibody
it's very
reactivity.
Early. Yeah. As you know, for the listeners, the knowledge of these antibodies, thank God for this team that found them, has only been around for 20 years, which is like a blip in, research.
Right.
Yeah. Yeah.
Yeah. There's definitely more research in that area. So fascinating, Erica. Resources. How do people find you, get in touch with you? What kind of resources do you have out there?
Yeah, so I have a Facebook group. It's called Person First Medicine for Down Syndrome. It kind of plays on the concept of person first language, right? Where we say a child with Down syndrome. And so they're people first, right? And the Down syndrome is just an aspect of who they are.
Love that. So
Person First Medicine for Down Syndrome. Hopefully that will be the title of my book someday. And then, of course, I have a website, pearsoncenter.com. And my Facebook page, I try to put as much information as possible as I can. I hold no secrets. There's no secret to what I do. I want, in my Facebook group too, I want all parents to benefit from this work. I don't want them to have to pay me. And I hope to pass these concepts on. It's challenging to do this on their own, but that they can learn from not only my Facebook page, my Facebook group. I do a little bit on Instagram. I'm not that great at social media. But and then certainly our website. Oh, my blog. I put as much blogs and articles and stuff to help as I can. Yeah.
Perfect. We'll get all that information and have that on your bio page on the webpage. So, Erica, thanks so much for joining me on this podcast, the interview, and thanks so much for all you do.
Yeah.
And you're doing some amazing work.
Thank you, Kurt. Yeah, I appreciate the opportunity.
Thank you.
This episode of Functional Medicine Doc Talk was proudly sponsored by Mosaic Diagnostics, a global pioneer in specialty diagnostic testing whose mission is focused on restoring health by addressing the root cause of complex chronic disease. For more information about this podcast, go to functionalmedicinedoctalk.com.